A 35-year-old woman comes to the physician with fatigue, nausea, and irregular menstrual periods. Laboratory studies show a potassium level of 5.6 milligrams per deciliter and eosinophils of 20%, normal range 1 to 5%. Her mother has a history of Hashimoto's thyroiditis. Which of the following is the most likely explanation of this patient's condition? Choice A, cestode infection. Choice B, antibody destruction of thyroid cells. Choice C, infection with a gram-negative diplococcus. Choice D, ACTH secreting pituitary adenoma. Choice E, autoimmune destruction of adrenal glands. Or choice F, deficiency of hydroxylase enzyme. I'll wait 5 seconds and answer the question. So this patient's fatigue, nausea, and irregular menstrual periods are suggestive of Addison's disease. Especially with this history of autoimmune disease in her family, it should make you suspect autoimmune destruction of her adrenal glands. So choice E, autoimmune destruction of adrenal glands, is the correct answer. Possibly due to autoimmune polyendocrine syndrome. As the name suggests, these are a constellation of autoimmune disorders where multiple different endocrine structures are affected. These tend to be very rare conditions, so I don't think you really need to know them for USMLE. That's just something you can go and read up on if you're curious about it. So this patient's hyperkalemia suggests low aldosterone, and that should help you narrow the differential down to a primary versus a secondary deficiency of the adrenal glands. Because if we were talking about a secondary adrenal insufficiency, then we would be talking about something like ACTH being affected, right? Which is not part of the RAS system, which affects aldosterone. So the fact that aldosterone is impacted means that there must be something wrong with the adrenal glands themselves, which of course we know contains the three areas of the cortex GFR, the glomerulosa, fasciculata, and reticularis, which produce hormones for salt, sugar, sex, respectively. Salt being aldosterone, of course, sugar being cortisol, and sex being the androgens. You can see I also gave an eosinophilia here, which is kind of a weird finding you tend to find with adrenal insufficiency because cortisol has a role in sequestering eosinophils in tissues and preventing their release from the bone marrow. So if somebody has low cortisol, like in the case of Addison's disease, you can sometimes find eosinophilia. So, of course, some of the other things you want to know about Addison's is that you could have myalgias, muscle pain, muscle aches, and you can also have hyperpigmentation, right? That's one of those buzzy findings you find sometimes. I didn't give it to you here because I felt like it would have been too easy. And there's plenty of NBME questions where they're asking about Addison's and they don't give you hyperpigmentation. But you do want to be aware that the reason hyperpigmentation happens is because POMC is cleaved into ACTH and MSH, melanocyte stimulating hormone. So in the case of Addison's, where I don't have cortisol being produced, I, of course, will no longer have the negative feedback on the upstream of the axis, which is to say ACTH production. So, because your body's going to produce more POMC to cleave into ACTH, it will also incidentally produce melanocyte stimulating hormone, MSH, which will cause the hyperpigmentation. And of course, that point about ACTH being high in Addison's is also another way you can differentiate it from a secondary cause. And again, I didn't give it to you here because there's going to be NBME questions where they don't give you every single criteria for it, right? So let's look at some of the other wrong answer choices here, right? Choice A, cestode infection. So obviously, some people, when they see the eosinophilia, they will reflexively start thinking helminth infection of some kind, with cestos specifically being tapeworms, right? Like Taenia solium, Taenia sagittata, and Diphyllobothrium latum. Any one of these can cause eosinophilia, of course, but this patient's other symptoms just are not typical of a helminth infection, right? I mean, I didn't give you ova, I didn't give you something that sounds like some kind of nutrient deficiency, and he also has no risk factors, right? She has no travel history. She didn't consume raw pork or fish or something like that. Just nothing here fits helminth infection other than the eosinophilia. Choice B, antibody destruction of thyroid cells. So obviously, this is one of those trap answer choices because I told you that her mother already had a history of Hashimoto's. And typically in MBME questions, when they give you Hashimoto's, it's going to be a hypothyroid picture, right? So the fatigue and irregular menstrual periods, that can be indicative of hypothyroid condition, but it doesn't explain a lot of symptoms here, right? It doesn't explain the hyperkalemia, doesn't explain the eosinophilia. The fact that her mother has Hashimoto's is more of a hint to you that there is an autoimmune history in family. And of course, thyroid plus adrenal destruction is part of the constellation of one of the autoimmune polyendocrine syndromes. Choice C, infection with the gram-negative Diplococcus. So this is referring to Neisseria infections, right? Which can cause Waterhouse-Friderichsen syndrome, which you usually see as a severe consequence of meningococcal sepsis. It can be caused by other bacteria, of course, but classically we tend to think of Neisseria meningitidis. And just to review, Waterhouse-Friderichsen syndrome, it's where you bleed into your adrenal glands, which can cause acute adrenal insufficiency. But usually when you get Waterhouse-Friderichsen syndrome, we're talking about the setting of sepsis already, right? So this patient has no infection symptoms of note. And typically when it happens, like you would be pretty sick already. So it would be mentioned in the question, right? It would mention probably that she has recurrent infections of some kind or that she's in really bad shape right now. And since Waterhouse-Friderichsen syndrome is acute, you wouldn't necessarily see the hyperkalemia or the eosinophilia. Choice D, ACTH secreting pituitary adenoma. So this, of course, is Cushing disease, where you have too much cortisol, right? So it's actually the opposite of what's going on in this question. So if anything, you would have a hypokalemia rather than a hyperkalemia. And of course, would think of a lot of the other things you would think of with Cushing's, which is like weight gain, moon face, buffalo hump. And of course, you also want to know that in Cushing disease, if you give a dexamethasone test, oftentimes you use the high dose dexamethasone test to differentiate Cushing disease from other causes of Cushing syndrome. Choice F, deficiency of hydroxylase enzyme. This is, of course, referring to congenital adrenal hyperplasia. Now, of course, in pretty much all of them, you can find low cortisol levels, but pretty much all of them present in infancy or young childhood rather than in an adult. And more importantly, of course, is because I'm deficient in a hydroxylase enzyme, and therefore I'll be low in one of the corticoids, depending on which one it is, I'm going to get a lack of negative feedback and then overproduce the ones that I'm not deficient in enzymes for, right? So, for example, in 21 hydroxylase deficiency, of course, we tend to think of an overproduction of androgens with low mineralocorticoids and glucocorticoids. For the 17 hydroxylase deficiency, we tend to think the opposite. We have an overproduction of mineralocorticoids and an underproduction of androgens. And in 11 deficiency, we tend to think of it being a mix of the two. The easy way of remembering this, of course, is that people have this mnemonic where they say you have more sex at 21, which tells you that the 21 deficiency gives you more sex hormone. And then you just remember that 11 is a hybrid of 21 and 17. And by process of elimination, you know that 17 you have more salt. Anyway, the point is that I would have an overproduction of either mineral corticoids, aldosterone, or of androgens, right? So in a woman, whichever one I get, I'm going to have the symptom of either hyper slash hypotension or underdevelopment slash hirsutism because again of the overproduction of mineralocorticoids or androgens respectively. So once again, the patient's age and symptoms just don't really fit. So bring it back, you really just want to know your core endocrine principles for these kind of adrenal questions, right? Because if you master the basic axis and remember that mineralocorticoids, glucocorticoids, and androgens in their respective places in your adrenal glands, and of course in the adrenal medulla you have the catecholamines. But a lot of times with questions like this, instead of going from the question into your diagnosis, you can just look at the answer choices and kind of reverse engineer your way there, right? Because you got to look at the answer choice and ask yourself, what would the clinical picture look like if this answer choice was correct? And as far as adrenal insufficiency specifically goes, you do want to know that autoimmune destruction is one of the most common reasons for it. I hope you found this video helpful. I'll see you in the next one.